Good afternoon, good morning, or good evening, depending on where you're joining us from. I'm in Geneva. My name is Vinh-Kim Nguyen, and with Suri Moon, I'm the co-director of the Global Health Center here at the Graduate Institute. It's a cold, cloudy fall day here, and so we're warming up here indoors, and we're looking forward to a very exciting discussion. I should just mention a few things about the center. We were founded over 10 years ago by Ilona Kickbush, and we're very excited to welcome everyone here to the second of our Open Global Health public events. So these events are dedicated to opening up the black box of global health and exploring how what lies within can be opened up to greater participation and diversity. At a moment where the global health community is rocked by accusations of systemic racism, and calls are being made increasingly to decolonize global health, we hope that our Open Global Health series will contribute to critical insights and practical solutions for achieving a more inclusive global health. So today we have perhaps a bit of a provocative topic. We're going to focus on the issue of data, real data, fake data, and accountability in global health. What we're trying to do here is to open up our understanding of data by moving beyond simple dichotomies of true or false, and to focus rather on the work of collecting data and how data works to produce better programs and accountability. And we have two really amazing speakers here, and it's quite a provocative combination, I should say. The first of our speakers that I'm delighted to welcome today is Mouhamadou Diagne, who has just recently joined the World Bank Group in Washington as Vice President of Integrity. In that function, he oversees the independent unit that investigates fraud and corrupt allegations. So not stuff for the lighthearted. It sort of sounds rather like dangerous stuff, as well as introducing best practices for preventing fraud and corruption. Previously, he led both the investigations and audit functions at the Global Fund for AIDS, Tuberculosis, and Malaria in Geneva. Our second intervenant or speaker today is Dr. Patricia Kingori, who is Senior Investigator at the Wellcome Center for Ethics and Humanities at the University of Oxford. Patricia is a sociologist who has performed extensive ethnographic research on social and ethical issues in public health as they emerge in field sites in West Africa and elsewhere in Africa. And her most recent publications concern data fabrication and the use of fakes in global health. But before turning the floor over to Patricia, we'll start with a straw poll and wait 40 seconds for the results. So the question is, in your opinion, health programs are developed based on data that are 100% reliable, mostly fabricated, 100% fabricated. And this is there's no mail-in ballots here. This is all live and online. We have 84% who say mostly reliable and 16% who say mostly fabricated. So let's see how that shifts after our discussion today. Patricia, over to you. You're on mute.
I hadn't appreciated I was unmuting myself, sorry. Hello, good afternoon, everyone. It's afternoon where I am, and it's a pleasure to be here and to talk to you about my work. So I'm going to be focusing on looking at the role and positions of frontline data collectors, so field workers mostly, in their conduct of biomedical research. And the context I'm specifically looking at is in African context. So I'm going to have 15 minutes, and in that time, I'm going to just basically touch on just some of the situations that they face and their everyday experiences. a key finding in my work is really around what is data, what constitutes data. And one of the things that I've found is actually data has very different meanings depending on where you are in the research hierarchy. So I'm focusing, as I said, on the fieldworker perspective. And one of the key questions often asked is, what is a point of data from the fieldworker's perspective? And how does this understanding of data from their perspective shape what they think of as real or fake data? So next slide, please. Given the time constraints, I thought actually one of the most effective ways of trying to communicate a fieldworker perspective about data and what is real or fake data is to present a couple of illustrations that I've co-created with them. So these illustrations were drawn not by me, unfortunately not even anywhere near good as this, but actually by an illustrator. And they were shown to field workers. And then over a period of time, they were continuously redrawn until we got something that the field workers were happy with, that they felt represented their perspective. So this is one, and there's also another illustration I'll show you in a minute. But if we're talking about data, and we're looking at this illustration is called What About This Other Child? So I'm going to speak a little bit about what's going on here. So a field worker, so this is the man holding the clipboard, comes to a research participant's house, which is a small boy standing in the illustration, and he's there to collect data. In the process of collecting, trying to collect the data, the mother of the house alerts him to a sick child in the house, a sibling, and he's asked to pay attention to this child. Now, on one understanding, this sick child has absolutely nothing to do with the data that he's about to collect, because the research participant involved is standing, is healthy, and they're actually, he's actually able to conduct and collect data from him. But from the field worker's perspective, the sick child is absolutely crucial, and everything turns on his ability to manage that relationship in terms of the quality of data he's able to collect. From field workers' perspective, an inability to reconcile this problem effectively can really shape the extent to which they're able to continue collecting data and the extent to which they're able to continue collecting high quality data. And this is where the fake and fabricated data enters this picture. So I'm just going to give you a quote from one of the field workers I spoke to. She explained something quite similar to this. So she said, there was a case where there was a child. The child had died in her sleep. The child just died. The mother woke up and found the child was dead. She told me and asked me if her other child could take her place, the place of the deceased pediatric participant, to get better care. How could I refuse? I just carried on collecting data, but from the other child. So what has happened here was that the children had been swapped into the project. Now, this is essentially a form of fabrication. It's a form of introducing another person into a trial that wasn't the research participant at all. And it was a way for this field worker to ensure that this child had got access to facilities and healthcare, but also to ensure, crucially, that there were community relationships and social bonds had been maintained. So what we're seeing here is that data is just more than just a collection of numbers. Data is actually embedded in community relationships, but also embedded in really problematic and demanding circumstances and real world contexts. And often it's the field worker who have to reconcile this in practice. So what that means is that they often are uncertain of what they're going to face, and as part of their toolkit to manage some of the problems they face in the field, data fabrication and fake data becomes a really important part of that. So in this scenario, often, and in other scenarios, data fabrication becomes a solution to a myriad of structural problems which must be reconciled in order for data to be collected. Can we see the next slide? So this illustration is called Data from Under a Tree. And actually data from under a tree is a euphemism for data fabrication. So it was, again, it was drawn in collaboration with the field workers, and the field workers, and the illustration depicts a scene where the field worker is supposed to go to a house, a compound, to collect data on a given day that they have no choice over. And when they arrive, a funeral is in place. So they know that they can't interrupt the funeral, but they also know that they have to collect data. And so the illustration in a way demonstrates the kind of tensions that they often face between having to have specific targets that don't bend to contextual, social, cultural norms, and that they're somehow in this position where they're having to reconcile these two things. So it's quite interesting that when we're thinking about what data is, we often think about the aim of data, and then we also often think about the methods in which the data is collected in order, when we're thinking about whether it's real or fake. So the process by which you collect data is also really important. It's not just the data itself. So fake data is often data that's seen to be not collected properly. And the reason why this this illustration is important is that often when field workers spoke about this kind of practice, the data from under the tree, they actually speak about it as if they are collecting real data. They feel from their interactions with the field and with people over time that they can predict answers in such a way that gives them real life responses. And this is interesting because then we have something which is a kind of a in between. It's genuine fake data. They're not out to just put any old rubbish down. If they put any rubbish down, then they know they're going to be caught because their supervisors will do random checks. And so they often try really hard to ensure that even though they're not adhering to the proper methods of collecting data, that the data that they collect reflects the context in which they work. So there's also that question. But the field workers themselves felt that there was some data that was easier to fabricate than others. For example, data that was that could be measured or verified easily, such as someone's height or weight, was probably more difficult to fabricate. But there were instances, for example, blood samples might be collected from people who weren't the participant. So blood samples, urine samples, stool samples were often fabricated if they needed to. Similarly, some data questions were also falsified, but to varying degrees of ease. There were certain questions that were specifically described as problematic and elicited specific types of responses. So food questions, questions related to sexual behavior were often the ones which field workers felt the most uncomfortable about. And while we understand the sexual behavior questions being fabricated, the food questions are ones that I found really, really interesting. So I'm going to read you a quote from one of the field workers who talks about fabricating questions around food. She says, I never ask those types of questions, as in questions around food. I just complete the questions myself because I already know how much these people eat. No one here eats 3 meals a day, but that's what I meant to ask them. So when you're taking the research drug, were you taking it with a meal? Now, this drug is meant to be taken 3 times a day. That means that they're supposed to be eating 3 meals a day. So I asked them, so if I asked them, you know, how many are you eating 3 meals a day? They will look at me like, where are those meals? Have you given me money for those, for the food? And we know that there's no food given as part of the research project. So I answer myself in the survey. For the ones with the shamba, which is a subsistence farm, I say twice a day. And for the ones without a shamba, I say once a day. But I also adjust to match the harvest times and such things. So what we have is a field worker who is using their own contextual knowledge to complete the data, to make it as real as possible, even though they're not asking those questions. And what's interesting is very rarely do field workers falsify entire surveys. What they tend to do is have sections of the surveys that they complete themselves, and then the other questions that they will ask participants. So that it's more often the case that they will miss out questions. So instead of thinking about real or fake data, it's often interesting to think about which parts of the data is real and which part of the data is fabricated, rather than thinking about a whole survey being fabricated. So this kind of genuine fake data is really different to just blatant sort of falsification or malpractice, because its intention is different. And in efforts, and really often what I found really interesting was this data from under the tree often took longer than if they actually asked the participants themselves. So it wasn't necessarily out of laziness or trying to save time. It was precisely to try and avoid the types of socially awkward, inappropriate types of contexts that are described in this illustration. So there's actual effort involved in trying to forge the responses to match research participants might provide. And I really want to go back to this point again around what is the point of data and what's the point of the aim and the motivations of science. So I've been working with field workers now for about 18 years. And in that time, I've only ever met 3 field workers who have had publications or seen the published data of any of the data that they collected. So there is at the moment a complete disconnect between the people who collect the data and also and the scientific aims of that data. And what that often means is that that vacuum is filled with a different aim and intention for data. Field workers themselves use data for different things. Does data becomes access to resources for participants, a way of maintaining social cohesion? So when we're thinking about real or fake data, part of that is looking at the motivations and also the work that data does in these contexts. Next slide, please. At this point, I'm just going to say thank you. And also I've referenced some of my work here if you would like to read any more about it. Thanks.
Thanks, Patricia. That was great. And look forward to discussing this. But without further ado, Mouhamadou, your turn.
Thanks, Vin. I certainly don't have that very interesting ethnographic perspectives on data. I never thought about it that way, but it's actually quite interesting to see that perspective in terms of how data can be manipulated in perhaps an unconscious or even subconscious way. So it will be interesting to perhaps explore that further. But my perspective is a much drier one from, I guess, an auditor or investigator's perspective, because we tend to look at a lot at data quality issues, and that's certainly been an area of focus over the past few years as part of my work. And in that context, let me just start with an anecdote, perhaps about a case we've seen not too long ago, maybe a couple of years ago, where one of the organizations in the field of global health intervening heavily in one of the West and Central African countries had commissioned a study which is called IBBS, Integrated Biobehavioral Survey, for those in the public health sector. These are studies that are mostly based on interviews and survey questionnaires to identify certain behavioral trends in some key risk groups. And it also tests disease prevalence data. And really the idea is, in many cases, to identify key behavioral risk factors in the prevalence of certain diseases such as HIV. It's quite important because it does inform a lot of program planning, assessments of the program, prioritization of the investments and the like. So it's a tool that's commonly used in that space. When we did an investigation in that particular country for that particular study that was done, that IBBS survey, what we found out was nearly a quarter, nearly 25% of the survey respondents were actually fictitious. These were not real survey respondents. The reported results in the case of the disease we were looking at largely deviated. The disease prevalence rate largely deviated from the verifiable lab results based on the actual tests that had been conducted. The survey provider did not conduct any confirmatory tests to validate the initial rapid test results, and many of the survey questions actually were not even included in the reported results because of data entry challenges, cost challenges, and the like. So bottom line is nearly a significant proportion of the data that was reported was essentially fake and was not real, including also the survey cost data for obvious financial reasons. So this was a perfect storm. The reason why I'm mentioning it is it was a perfect storm where you had a rogue service provider who was eager certainly to milk the system and maximize their own gain by putting less efforts into the survey, while still perhaps billing the program for the full budgeted amount. You have a rogue service provider, you have inadequate data quality controls because none of these were actually caught before the investigation was done. Inexistent or very weak supervision and monitoring over the work that was being done, and just in general, the lack of a robust framework for validating and providing assurance over data collection. Now, to be quite clear, this type of fraud that I just highlighted, there is no overwhelming evidence that it is a pervasive or systematic issues in the health programs. And actually, I'm quite heartened by the survey, the straw poll survey results that shows that 85% of the people in this room, this virtual room, actually believe that by and large, the data is reliable. So I think that's kind of consistent with what I'm saying, that there is no evidence that data fraud and data manipulation is a pervasive issue across the system. On the flip side, though, the underlying root causes that enabled this particular fraud, the things I talked about, the limitations in data quality control, the lack of comprehensive data quality frameworks, the weak quality control processes, limited accountabilities in the process, these root causes tend to be far more prevalent and do present significant limitations in the reliability of the data, even though it might not be a case of fraud. In some cases, it might just be a case of the data is not robust enough to serve the intended purposes. And I think as we look into it, we need to be very clear. These are complex issues. If they were simple issues, they would have been resolved a long time ago. These are complex issues that have several dimensions, and they involve very daunting challenges that we should not underestimate. First of all, I think we need to take into account the environments in which these types of data are being collected. These are generally environments where there is lack of resources, pretty weak infrastructure, limited capacity in terms of human resources and the like. So it's a very limiting environment that we should not underestimate. It makes the task of collecting quality data quite a daunting one. And the other thing to keep in mind is data is just one part of the broader equation. And generally, the data issues we are actually identifying and highlighting are just a symptom or a reflection of a broader lack of maturity in the overall health system as a whole. So I think that's also a contextual factor that we need to take into account. That being said, I think we need to be able to recognize that there are many challenges that will need to be addressed if we want to get to better quality of data in the area of public health. One, I think we see a lot gaps in what's referred to as M&E systems, the monitoring and evaluation systems, both at the national levels, but also, quite frankly, in some cases, at the level of the organizations that often fund the programs. And what I mean by the M&E systems is the lack of clear and consistent indicators, identification of reliable data sources in order to be able to track those indicators, linkage to data collection methods and robust data validation processes in place to make sure that actually the data we are collecting and using has been subjected to rigorous validation before it is actually being used, and consistent guidelines for the analysis, the use, and the reporting of that data. That end-to-end framework, from the definition of the indicators all the way to the validation of the data and guidelines for its use. In many organizations, it still tends to be ad hoc, and certainly it tends to be quite weak or even inexistent. in many of the countries in which these data collection activities are taking place. So I think that that is an underlying factor that we need to take into account, just the weakness of the M&E systems. Second, I think there is also often a challenge with target setting and the reliability of the metrics based on which we are collecting data. These challenges increase as you expand beyond typical treatment programs into softer areas, as we've seen in recent years, with many organizations and many programs focusing on quote unquote soft areas such as prevention activities, access for key populations, human rights issues, which do have a lot of correlations to health programs. These are much more difficult. The metrics are much more difficult to measure. It's easy to measure the number of patients you put on treatment, but when you get into measuring indicators around things like human rights, for example, it's a bit more subjective, and the indicators tend to be a bit less reliable. So I think that that's one thing we have to take into account. And the more you move from input and output metrics that tend to be relatively easy to measure into metrics of outcome and particularly impact, then you're running into much more significant challenges around data definition, the nature of the metrics, the measurement methodology, and the like. So the challenge is just bigger. That's also another factor we have to take into account. Third, it's an area that we don't talk a lot about very often, but it has significant ramifications for quality of data. It's the challenges with limited human resources for help. You travel to many of these countries, actually, who is collecting the data at the facility level? I'm not talking about what's happening in the Ministry of Health or the central structures, but quite frankly, the basic data gets collected at the facility level, at the villages and the like. Well, who's collecting that data? Generally, it's a health worker who in a normal day from dawn to dusk, they are extremely busy actually treating patients, dozens of them, if not hundreds of them. The last thing on that person's mind is probably data collection and validating data. Their number one job, and rightfully so, is to take care of patients. So limitations in terms of availability of human resources and how thin those human resources are stretched at the basic level of collection, which generally is the facility or the village, that is a problem. And sometimes also the training of those limited resources that are available. And there is another dimension in terms of the human resources, which is the limited leverage of community systems. And this is particularly important as you get into areas such as dealing with key populations that are stigmatized, where the trust factor is extremely important in order to be able to collect reliable and meaningful data. If the individuals do not trust the peers who are collecting the data, that could be quite problematic in terms of their willingness to share meaningful information. So I think that's also the role of communities workers is extremely important from that standpoint, who are connected directly to the community. Then I think you have significant limitations in the health data systems and the tools. And quite honestly, I believe that meaningful efforts and investments have been made over the past few years that have significantly contributed to the availability of data in many countries, such as, for example, the rollout of so-called HMIS, health management information systems. There has been significant progress over the past few years in many of the countries that I have seen. But whilst that has increased availability, it has not had as much of an impact on quality and completeness of the data, because it's not just a matter of the data being available, but how reliable it is it complete, and what is the underlying quality. There, I think there is still ways to go. And also, I think the lack of consistency and triangulation amongst the different data elements, which generally is due to lack of interoperability between different systems in the mix. For example, in many countries, you see some pretty significant differences between the insights you're getting from the logistics management information systems that give you supply chain data around, for example, commodities that have been distributed to populations, versus the data coming from the HMIS, the health management information system. To give you an example, in one country we've looked at a couple of years back actually, there was a 40% delta between the drugs consumption data from the health management information system, how many drugs were being consumed by patients versus the drug availability and distribution data for the logistics management information system. And there was no way to reconcile the two. And now, is it the procurement data that's correct, or is it the consumption data that's correct? And really telling the difference between, is there leakage, is there overconsumption, is it just bad data entry? It's extremely hard to sort out, just because the systems don't talk between themselves, and it's very hard to reconcile between these different systems. Then I think there is the broader issue of just limited assurance and verification processes that often result into material inconsistencies between the data that's being reported and what can actually be validated at the data collection points. Again, to give you some examples, we've looked at countries in which, quite frankly, you had variations in the double digits, in some cases well over 50% variation between the reported data and the data that we were able to verify at the facility level, whether it had to do with number of patients being treated, or pregnant women enrolled in certain programs, or adolescent girls rich, what have you not. So generally, part of the problem is the assurance mechanisms are relatively weaker on the data side. I think there is still a bias in many programs to focus assurance mechanisms on the financial side, verifying the use of the money, verifying the use of funds, and perhaps a little less focus, if you will, being put on validation of data. And I think part of it is, quite frankly, just a higher tolerance still for these data issues as compared to the tolerance we have for, let's say, for example, fraud or bad financial management. And that risk appetite, which is biased towards mitigating financial risk, generally means a lot of the resources are not put into verifying program quality or data quality, as opposed to verifying use of funds. And then I think lastly, at the organizational level, for many of the organizations that are intervening in this field, there are still some significant challenges around having an end-to-end data management framework with clear roles and responsibilities, formalized processes around, for example, quality assurance over the data that's being used and that's being reported, and also enabling technology platforms that really allows us to use the data in the most consistent and validated in the most effective manner per se. So I think these are some of the issues that we have seen that certainly have had a significant impact on the quality of the data that we've been auditing over the past few years. And I think looking forward, it seems to me that some of the focus areas to improve data quality will have to be around perhaps more targeted investments into well-integrated systems, a focus on human resources to really alleviate the enormous pressure on workers who generally are responsible for collecting the data, strengthening supervision and monitoring, and really having robust assurance and quality control mechanisms so that the data we use is subject to effective validation before it is used for decision making. So let me stop there, and happy to take perhaps some questions in the Q&A. Back to you, Vin.
So just to explain to the audience what we're going to do now, I'm going to say a couple of things and then just quick questions and answers between if Patricia and Mouhamadou want to have questions for each other before we open it up. Wow, this is a bit of a challenge, but I think something that to sort of tie these two talks together, something that struck me is that in what you said, Mouhamadou, is this question of data collection or data quality really being secondary to the task at hand in many of these facilities. And I think that's very useful because Patricia is really giving us a perspective from the kind of the Rolls Royce, right? So research, these are people who are specifically funded only to collect data. And even there, we see a number of issues coming up around data quality, if you will. But whose quality for what, I think, is really the question here. Patricia, I thought what was really fascinating in what you pointed out is that the data is fake, but it's a solution to problems. So for who is the question, right? So presumably at a certain level, people want a particular quality of data or data to reflect something like what do people answer when you ask them when they're hungry. Whereas the people who are collecting the data are trying to solve problems at a whole different level. So Mouhamadou, when you talk about this kind of end-to-end data management framework, I think it really, you can imagine that at different steps, different things are at stake. And I think that would be kind of an interesting area to look at. I think what really struck me, Patricia, and I think this links to something Mouhamadou said in an interesting way. Maybe I'll start with what Mouhamadou said. He said, well, you know, if it's just input and output indicators, you know, like how many mosquito nets were distributed, or how many people came to sensibilisation, I don't know the word in English, but a training exercise, that's easy. There's not going to be much debate there. But when it comes to what you said, I think the term you used was softer indicators, right, that are more subjective. I think this is where it becomes very interesting, because Patricia's hunger indicators are both soft and hard, but the softness of it actually allows more subjectivity, which allows more truth in a way, to better reflect what people know is going on. So I was really struck by this kind of continuum between sort of very objective, cut and dried, almost operational metrics, and ones which require some degree of judgment and of assessment of context. But I don't know if Patricia, you had questions for Mouhamadou or vice versa.
I thought it was a really interesting presentation. I really liked the insight, the anecdote about the healthcare professional really overstretched and doing lots of other things, and then on top of that being asked to collect data, because ultimately I think it really strikes at the heart of the work that I'm doing, which is how do people on the front line, how do they understand this data collection? What efforts have been invested in explaining to them what exactly is they're doing and for what? Because I've seen examples of best practice where people have spent a lot of time really investing in motivating and explaining what the data collection is for and what it can do, and seeing much more adherence to going the extra mile, which is essentially what you have to do to collect data. You've got to, in a hospital settings, find patients, track them, wait for them, you know, you have, it's something that is quite inconvenient. It doesn't slot very neatly into everyday life data collection. You know, there's no space in people's life that they leave aside to be part of a research project. So it means asking people essentially to use all sorts of other skills and resources to motivate themselves and the research participants to do this, and often done against a background of not actually knowing what the data is for, never seeing any of the output, never having anybody come to them and explaining the aggregate findings. So I found that really interesting. I thought that insight really captured at the heart of it, I think, where we are at the moment with real and fake data, which is from the position of people on the front line. This is all a kind of fakery because they don't see any of it. You know, they don't see any material differences in being involved in data collection. So I just wondered whether any of that resonated with your experiences.
Yeah, no, that's quite true. I mean, I think in terms of the data collection process, I think you see both groups significantly involved, because you do have the routine data collection processes, and that's really the piece I was talking more about, where the data is collected on a routine basis at the facility level, and that's where generally the health workers are heavily relied on, whether it's the nurse who is at the health facility taking registers, keeping registers of patients treated and the like. But you also have what's the supplement to it, which is in many cases, in terms of public health, it's not just the routine data collection that's happening on a routine basis, but also the surveys that are done on a periodic basis. And that's where I think, Patricia, your observations come into play, because you're right, in those situations, it's not the health worker who is generally responsible for those. It's like the census, you hire some people to do it on an ad hoc and temporary basis, and certainly how you train those people, their understanding of the use of the data, all of those things are important. But you might also argue that at the end of the day, it's much more of a mechanical process where you would expect them, based on very defined and rigorous processes, to just go in and collect data based on certain agreed open parameters, regardless of what it will be used for later on. But I think where it becomes really interesting is when you talk about areas where there might be cultural sensitivities, like, for example, going into villages and talking to elders, or in general, the populations around sensitive topics, such as, for example, sexual practices. To what extent do you expect actually the people to use their understanding of cultural norms to adapt them in order to be able to obtain the appropriate answers, or even to be able to establish the connection with the community? And I think from that standpoint, I was really interested in your research showing that not that people want to manipulate the data, but they think there is a better way of obtaining the appropriate information by calibrating them to the social and cultural values of the community. I think that's quite an interesting perspective that I initially did not think about.
I just wanted to add something that struck me just with this, I was reminded of when you, in your question, Patricia, because one of the things you said is that, and this is really, I think, is worth underscoring, only 3 of the field workers that you've worked with over 18 years, and I imagine that is very few, have ever seen what the data, the output of the data. And this is a very interesting link to the importance of open global health, or decolonizing global health, right? Decolonizing in the sense of, we have these kind of colonial, and I mean that not in a, oh, it's so bad way, but it is a description where you have sort of the decision makers and the centers of data analysis being located very, very, very far from where the data is collected, right? And with a kind of a power gradient all the way along. And that produces this kind of phenomena of the fabrication of data for local ends, because people don't understand what else it can be used for. They never see the end result. So I thought that was very striking, that decolonizing is about better data and better health outcomes. And we've talked, we've talked about Africa, but I thought it's important to share an anecdote. I have a secret life as a physician, and I work in a large academic hospital where data is collected in real time on admissions, on length of stay, on how many minutes till a blood test to a result, and a consultant sees the patient, and so on. So these are all performance indicators. I will not say the name of the city, the country, or the hospital. And these data are, as I said, collected in real time and are monitored throughout the day by officials at the Ministry of Health to see that, how the system is doing. And I learned recently, in the context of the epidemic, I actually realized that a lot of the data that was being plugged into this software was fake. Can you imagine it? I mean, so people were reverse engineering diagnoses. So basically, if patients stay beyond a certain amount of time, they have to be hospitalized, etc. And people were adjusting the data. It's exactly what you're describing, Patricia. We're adjusting the data to what they felt would be a better outcome for the patient, so that the management would, adjusting the data so that they wouldn't get in trouble for the way they were managing the patient. So this is not just an African story. This is something that happens everywhere. I don't know, Mouhamadou, did you have some? Yeah, Patricia, go ahead.
Just to add to that point, part of the reason why this happens is actually about the human contact. There is something about having to face somebody else in need, or having to face an awkward situation, whether it be in Europe, whether it be in Africa, whether it be in Southeast Asia, that forces you to take on a different relationship, even if your intention was to go in there and act like a robot, extract data and come out. If you're faced with a sick child, or if you're faced with a mother saying, if you don't let this child into this study, right, then there's going to be real problems here because I can't afford healthcare. There are very few people who could respond to that. And I actually think that it's, while I accept the point about the difference between routine data collection and actually ad hoc surveys, sometimes with the field workers I met who were involved in routine data collection, so they were with, demographic household surveys where they'd have to go to the same house, they often were the ones who were more embedded in these intractable social obligations, because they were like, well, you've known this child since this child was born, now the child needs you. I mean, I've had field workers who've been have children named after them, or they're actually so embedded in these relationships over many years that actually when the family then turns around and says, I need this or I need that, if the field worker can't give it to them, they end up avoiding those households. They've known that family for so long that they can actually complete the data themselves. So this is about kind of social relationships, actually, in the way in which the collection of data places field workers in these kinds of social situations that they often have to try to find ways to reconcile. They use their own money to buy food, they pay for funeral expenses, and sometimes they fabricate data.
Mouhamadou, did you have any questions for Patricia?
I think from the standpoint of the impact of these behaviors on the reliability of data that's being used in the public health domain, one overarching question is how pervasive do we think this is, right? Which maybe goes back to the initial straw poll questions that you did, because certainly if these are isolated instances that we have seen, the impact would be far less significant than, in fact, if we do believe that this is a pervasive occurrence in the field of public health, because the reality is it's not just the routine data collection processes, but also a number of decisions, program planning, and the like depends heavily on the reliability of the data collected through surveys. And increasingly, I think people are recognizing, and I alluded to it a little bit, the use of workers who are embedded in the community, and generally it's seen as a positive thing. It's a great thing because they understand the cultural norms, they are trusted by the communities and the like. But if the flip side of it is actually that could result in more biased collection of data, then I think that introduces an interesting dimension. So I think one of the questions, and I don't know if Patricia has the answer or not, is how pervasive do we think this is? Is it a pervasive occurrence, or are these isolated instances that we have seen?
I think for the field workers I've spoken to, most of them would say that they have fabricated data. And that could be anything from the modification of questions to the collection of samples from other people. So they know, for example, that Vinh-Kim really doesn't want to give blood, but he's happy to take part in the survey. So they might take 2 samples from me and none from Vinh-Kim, but keep him in the survey, but just never take blood. What I find really interesting isn't necessarily the pervasiveness of it, but the impact. So there was a great South African study where they found out that their field workers were fabricating data. And they redid the study, this time with the field workers completely adhering to all of the study protocol. And I think in the initial situation, that it was the vast majority of the field workers were fabricating data. When they redid it, everybody had adhered to the study protocol, and they only found a 7% discrepancy between what the field workers had entered as fake data and the real data, which means actually that what the field workers do is go to incredible lengths actually to try and get real data. And the reason why they do that is because they don't want to lose their jobs. They know that they have to try to get good data, and good data matters, but the value of the data differs. So they're getting good data because they don't want to lose their jobs, but actually getting good data means that you can use the data for scientific purposes or health purposes. So from what I'm interested in here is the way that the data takes on different meaning depending on your perspective to that data and your relationship to it.
So what I'm going to do now, I'm conscious of time, and there's a lot of great questions. So I think what I'll do is I'll go through the list of questions and hand it over to you. The first one is perhaps an awkward one. I don't know. It is, does or did the Global Fund have a robust data validation system? We can guess that that's more for Mouhamadou to answer.
Yeah.
Well, first of all, let me just put a disclaimer out there, which is that I no longer work for the Global Fund, so it would really be a bit inappropriate for me to make any comments related to the organization. Look, I mean, I think in general, with that caveat, as I indicated earlier, this is a complex issue. Part of it is certainly what the organization does, but part of it is also the environments in which we operate. And in many cases, the organization using the data is subject to the limitations in country. It's pretty much garbage in, garbage out. If garbage is collected, I mean, no matter what validation processes you might have at the organization or corporate level, you're still going to be facing some limitations. Short answer, without getting into too many details, is I do believe that, like many other organizations, processes have significantly improved and continue to improve, but certainly there are gaps in many of the areas that I highlighted, which I think that organization and many of the sister organizations are quite aware of. But I think that's what I would say.
Thanks, Mouhamadou. So a spectator I think this is just a comment, which I think we would all agree with, which is that the fabrication of data is politically driven and is sometimes done to impress politicians and donors. Although this, I think, is not what you were describing, Patricia. People are just trying to, and I think this is where your work is so important, is that it's about achieving local results. Wouldn't you agree?
Yeah, I mean, I think the idea that fabrication of data is political ignores the fact, or at least doesn't focus on the fact that all data collection is political, right? So it's and there's different types of politics. I think what the field workers are interested in is actually often just fixing the issues that's in front of them, and data fabrication is part of a toolkit of other things that they do. So, for example, it's interesting to me that people tend not to be up in arms about the fact that field workers actually pay for a lot of the thing, a lot of food for participants. They often contribute things like funeral expenses. And out of everybody in the whole data collection hierarchy, they actually give more of their expenses to participants than anybody else. Given that they're paid the least, there are kind of questions here about ethics. And often when they fabricate data is when they know that they actually can't afford to go into households, or they can't fix this problem any other way. So I think, where our kind of concern or moral outrage is here is also quite interesting to me. That, on the one hand, that we've got these people who are essentially put in these really difficult situations. And the reason why they're there in the first place is because the whole world recognizes that there's a need and these situations are challenging. They wouldn't be collecting data in situations where, for healthcare reasons, if we had any other solutions. So we know there are problems, but that is never funded. Those kind of frontline workers never get the kind of support that they need. And so data fabrication is part of that. But I think what the questions alludes to is much larger sort of questions around the politics of data fabrication. And I would actually argue to a certain extent, given that many governments say that they don't even get often the data results back once they've given it to bigger states, bigger institutions. So you can have universities collect data in a country and never feel that they can give it back to never give the results back to the country. That fabrication might be part of that, but there's no value actually for the data because people don't feel invested in the process or invested in what comes out the other side.
Thanks, Patricia. So I think this is a question for both of you from Loretta Wong, who asks that notes that as an activist, she and we in general rely on data to drive advocacy work. So how can we advocate more wisely given that there are so many loopholes in the data and data quality? Tough question to answer, but I'm wondering if either of you has an answer.
I mean, Loretta, number one, I want to go back to what I indicated earlier, that there are a lot of issues with the data in many cases, but by and large, I think we need to focus on big picture. Does it tell us, are the trends meaningful? Are we seeing meaningful trends? Because you could have errors in the data or some of the data elements, this part of it may be inaccurate or even fake to some extent, but by and large, is the big picture itself directionally indicating us where we are and what the trends are. And from that standpoint, I do believe that despite all the limitations, at the big picture level, the general trends and the general outcomes that we are seeing from the data tend to be fairly sensible one. And generally, when you talk about advocacy, I think it's less about specific elements of data or specific elements of the program, but more so around the general direction and the general trends. And from that standpoint, it is still my belief that despite all the limitations, that data is quite usable. The other thing that I would be saying is there is a role actually, even from an advocacy standpoint, in terms of not just being a consumer of the data, but actually influencing perhaps how that data is collected. And one of the specific areas I talked about is perhaps better use, maybe not more use, but better use and smarter use of community systems and community advocates in terms of areas, for example, that are much more sensitive, such as dealing with key populations, dealing with issues of human rights and the like, which I know you're very involved in. I think there is an advocacy role in making sure that there is increased use of those partnerships to improve the quality of the data that's being collected. So I think there is also a role besides just being a consumer, but also maybe strengthening the partnerships to lead to better data collection processes.
So a question specifically for you, Mouhamadou, you're in the hot seat today, it looks like, from Robert Smith. Can you comment on what role digital infrastructures can do to improve the quality of data across the health system, specifically in respect to interoperability? You did mention, allude to that a bit. So data and technology interoperability.
No, I think the use of technology clearly opens up great opportunities to improve the quality of the data. Like I said, first of all, availability has been significantly improved, and in large part because of the availability of systems such as the ones that I just talked about. So it does help a lot in terms of collection, in terms of aggregation, but also in an area that I just talked about, triangulation of the data and identifying inconsistencies. It's clear that it's easier to do that using digital platforms and advanced systems as opposed to manual processes that may have been around in many places for quite some time. But I think we need to have very clear strategies as to how we deploy those technologies and how we make sure that actually they are well integrated within the system. Because quite frankly, part of the issue in my view has been in many cases, lots of investments having been made, but sometimes made in silo and not part of a broader national strategy around data quality, around monitoring and evaluation systems, multiple donors intervening sometimes in the same country and creating parallel systems, collecting all sorts of data without having an overarching strategy. So I think that can be extremely helpful. And we have already seen very positive outcomes, particularly when it comes to availability. But I think there is a need to make sure that those investments are not in isolation, but part of a broader national strategy that takes into account the broader objectives of the country, but also what is the role of each investment and how it can help achieve those objectives. So I think it's more a matter of having a strategic approach to it as opposed to an ad hoc investment on isolated systems.
And I would guess a very global approach, right? Because knowing about my experience with the electronic medical records, the real difficulty is everybody starts doing their own thing, and then it just becomes a mess to get these different systems to be interoperable. Patricia, a question from Surabi Agrawal. She notes that often some of the poor practices in data collection are driven by the need to meet survey targets. For example, teams that are required to complete a large number of interviews per day tend to spend less time per interview, which can significantly compromise the overall quality. Do you think this is a problem that needs to be addressed by the quality of data collection teams, or is it more a systemic problem of target-driven research?
Thanks, that's a really great question. And I think actually the answer is both of those things. So the target issue is a real issue, and that was really a part of the data under the tree illustration, was just the inflexibility sometimes of these targets. You know, no matter what is going on, whether it be a kind of flooding that happens, heavy rains, a funeral, field workers and frontline data collectors are expected to collect the data. And really at the heart of this often is lack of insight into what's involved in data collection, because anybody that's involved in actually having to physically go out and walk in these sort of conditions, and often many of these places are only accessible on foot if you're doing it in rural areas, or even in urban areas, you know, you're facing all sorts of dangers. In hospital settings, it's very difficult. Anybody that's actually involved in collecting that data know how difficult it is to meet targets. And this is even by the most motivated and willing person. The problem is that often these people are so low on the hierarchy, they can't feed back up to say, actually, these targets are just inoperable in real world settings. So everybody accepts what's happening. Field workers will try their best to fit the data that they've got and into the time that they have. But ultimately, there is something about this kind of rapid data collection, which on the one hand can be justified, on the other hand makes it really difficult actually to collect good quality data. So I think there are sort of questions around not only the types of targets, but also sometimes the length of the surveys. Field workers themselves wonder sometimes why these questions. So this is really looking at the kind of relationships that there are really around data. You know, how often is there room for people who are actually on the front line of collecting these data to feed back to the people who are designing projects to say, this just isn't operable, it's not working, these targets don't work. And for that to be taken seriously and for them not to be seen as being lazy or trying to shirk off their work, but actually to really listen to what's happening. Because ultimately, I think for the most part, most people are motivated to try and do a decent job. You know, they want to keep their jobs. It's often in places where there are very high unemployment rates. People want to work and do good work. But if the system and the structure is making that difficult, then people will find ways around that. And so I think actually, in response to the question, it's actually probably both of those things.
So just for the audience members, I'm not going in order of questions because there's a kind of a flow. So I'm going to use your answer segue to Patricia, to segue into Fanny's question, which I think speaks directly to what you've been saying, which is she asks, she knows it's tricky to put into place, but has anyone already tried to involve field workers in the design of research protocols? If they are part of the process at the beginning, she notes they could understand the aim of the research, improve the quality of data collection, and also bring their experience of the community and situation that they could face in real life. So do you know of any examples of this, Patricia?
I've come across one example, and it worked really well. And I think, and the reason why it worked well was actually, apart from anything else, it really motivated the field workers to feel like this can't fail if I've been the person that's been part of inputting this, you know, the questions and thinking that through. Now, I think that's often it's rare, because you can imagine often studies are designed well in advance, then field workers are presented with things. Often the relationship with the person who designed the project and the field workers, it's got lots of intermediaries there. So there's actually not often a very close relationship. So if you go back to the healthcare worker that Mouhamadou described, and then think about the Minister of Health, often the gap is that large, you know, the difference between the person collecting the data and the person who's either designed it or going to use it. So I feel that when we're talking, and this is a very common idea, this idea about community engagement and participant engagement, I think that often there's a step that's missed out. Nobody actually goes back to field workers and data collectors and actually try to engage them. And I think that they would be a really important source of knowledge and information as to how we can better design some of these projects.
Certainly is a very promising avenue. I think this is more for Mouhamadou from Meg Davis, who asks, isn't part of the problem with data accuracy that of shifting and evolving methodologies and indicators? Are global health agencies constantly shifting the goalposts? What do you think?
Yeah, I mean, I think, Meg, that's a very good question. It is a challenging one, though, right? Because on the one hand, I do believe that you have to have stable indicators. I've talked about the need for consistency in some of the indicators, definitional issues around the metrics and what type of data we need to collect to measure those metrics. So certainly, I hear it loud and clear. That is absolutely a valid concern about having consistency. At the same time, though, I think these things are not cast in stone, particularly in some of the areas that I just talked about, what I refer to as some of the soft areas. And quite honestly, I think the situation of crisis that we've been living over the past few months is a perfect illustration, right? Which is, and we've heard it a lot, we've heard a certain number of things related to COVID back at the beginning of this year, around March and April, and fast forward 5 or 6 months, you're hearing completely the opposite. And sometimes the arguments you will hear from practitioners is, we have to adjust as we get additional information. And the more we go into this crisis, the more we learn, and the more some of the initial assumptions we had made turn out to be assumptions that need to be adjusted. So I think there is that element of flexibility that needs to be built into every process, that as you get additional information and you find better ways perhaps to structure a program or to measure certain indicators, you should have the flexibility to make those adjustments. But at the same time, how do you balance that versus having a certain level of consistency is a valid question. And in some cases, quite frankly, based on my own experience, even within the context of the same programs in the same place during the same time period, you can see some pretty significant differences in terms of how different people or different program implementers would define different metrics and measure them accordingly. You go into a so-called AGYW, Adolescent Girls and Young Women's Program, which is something that many of the agencies have been focusing on a lot in recent years. Well, what does it mean that we've reached actually an adolescent girl and young woman? What type of reach are we talking about? In some cases, are you just measuring the adolescent girls and young women who signed up for the program? Is someone else measuring anyone who benefited from one aspect of the program, such as a module? Is a third one actually not considered an adolescent girl rich until they have completed the whole cycle of the program? Depending on how you define it, you can have very drastically different numbers in terms of how many of them you have reached. And sometimes it happens within the same country, in the same programs, and at the same time. Those inconsistencies, I think, can be problematic. And the more we standardize and harmonize our definitions and metrics, probably the better. But at the same time, again, I would be very careful not to make these things so rigid that actually you don't have the possibility of adjusting your methodologies and your indicators based on additional and better information.
Maybe to respond to that, there's a comment here that I'm not sure I completely understand, from Gerald Schatz, who says, what I hear here suggests that for public health survey purposes, so what we've just been talking about, anecdotal reports of anomalous developments would be more valuable and actionable than classic maths perfect epidemiology, sort of standardized surveys. So reporting, identifying the problems, the anomalies. So he asks, how do the panelists feel about this? So it's a methodological question, and it's a little bit difficult for me to parse exactly what Gerald is referring to, but if any of you have, have some insight here.
Look, I'll say the same thing. I'm not a specialist by any means of, you know, public health surveys or data design per se in the public health arena. So maybe that would be a question more for specialists in that area. But just on the surface of it, I would be very skeptical of an approach that's entirely based on anomalous developments. I think this is an area where probably you want to have systematic information, whether you collect it on a routine basis or some very structured survey, which are probably well designed, as opposed to just picking up anomalies here and there, because sometimes anomalies may not be indicative of a trend. And really what we want to focus on is meaningful trends. Would be my layman's, I think, reaction to this, but interesting question.
There's a question here, I think, which would be for both of you, having to do, perhaps more so Patricia. So what does the panel think? This is from an anonymous audience member. What does the panel think of giving token financial incentives for participation? Maybe Patricia, you can answer that. That's a fairly classical question, I would say.
Yeah, I'm not quite sure what tokens of financial incentives mean.
Well, actually, she or he says reimburse and pay a fee, high income, not very clear. But I think what is suggested here is that patients be. The question is a bit. Yeah, one is reimbursement of expenses and maybe a small and pay a fee, a small incentive. And cadeau.
Yeah. Well, I mean, that happens already, and it happens in ways that, you know, to varying degrees, people are happy or not happy with. And, you know, I think the question is what's the aim and what are you trying to do? So some people say, well, you know, this is subsistence farmers and they've taken the time out to be part of research, so we should give them a day's wage for their time. And that's just a time reimbursement. And other people feel that actually that in of itself is inducing people into doing things that they ordinarily wouldn't do, or being involved in projects and research that maybe they mightn't do had they not been given that fund. I think that's really, really difficult. And I do think I think if I understand the question right, there is something interesting about the fact that we're much more comfortable to give money to people who already have it than money to people who haven't. So talking about the high income context, you know, if I was to take part in a clinical trial in the UK, I would be treated very well in some respects. And there was a really interesting case a few years ago. I think it became dubbed like the Elephant Man case. Some students took part in research, and it was an MRC funded project, and they had some very serious adverse consequences as a result. And I think somebody got their limb amputated, and in the process they got paid quite a lot of money, and everybody thought that would be the end actually of clinical trials in the UK. It turned out it was like a sort of perverse advertisement, and lots of people wanted to be part of projects because they didn't even know that you could get paid to do them. I think in much more poorer context, these things have a really interesting dynamic, because on one hand, there have been research that showed that actually you need to do very little to act as an incentive for people in projects, you know. Some people have said as much as a bar of soap or a t-shirt is enough. And other people have said, well, if you're going to do that, then why don't you just pay people properly and actually just give them a wage and treat them like laborers and employees for the time that they're involved in projects? I mean, these are really complex ethical questions, and it does shape the way that data is collected. And I don't think there is a resolution to these problems. But in the meantime, while we're trying to fix it and have academic and policy discussions around this, field workers are buying people food. They are paying for all sorts of things out of pocket. So it's the people on the front line that try to reconcile this. And there are some people who design projects who know this. So some of the projects where field workers have felt the least amount of ethical dilemmas have been where the principal investigator or lead researcher have actually got a kind of kitty for these kinds of funds. You know, somebody needs to go to the hospital, there's some money in there that field workers can access to pay for transportation fees for funeral expenses, or make a contribution to funeral expenses. And so field workers don't have to use their own money. So what I'm saying is actually these are really complex questions, but in the meantime, it doesn't mean that they go away because we can't solve them. In the meantime, field workers are trying to find ways to fix those problems. And we could very well learn something from paying attention to how they fix some of these problems around incentives and inducements and things.
I mean, what I would say is, in general, I think the use of incentives in public health programs is nothing new. It's already pretty much in there in some aspects of public health program. For example, when it comes to adherence, it is not uncommon for many programs to actually incentivize participants in certain treatment programs through nutritional supplements, for example, in the case of, for example, TB patients, or other types of incentive to make sure that they adhere to the program and they do not drop out. So the idea of incentive is there already. What I'm not sure about is the potential pitfalls of paying people to participate in survey. I think it's an interesting idea, but I think you would have to think through what could be the perverse incentives that you might be creating. As an example, could you create an incentive for someone to duplicate answers and participate in the same survey multiple times, especially if the data collection points are different, just because they are interested in whatever the payment is. It's just an example, but I think you need to think it through. How would you use incentives without necessarily creating perverse behaviors and unintended consequences?
Question for you, Mouhamadou, I think from Jessica Amenda, who says, can we consider a situation where we hire people other than the nurses to do data collection? Because I think she's referring to, you'd mentioned the facilities, the problem of who is collecting data in health facilities. Why don't we hire other people to do this work?
Yeah, that's a great question, Jessica, but I think you run into the same issue, which is the issue of resource constraint, right? In an ideal situation, you would want to hire enough doctors, enough nurses, enough lab technicians, enough data collectors. You would hire enough of everything. The reality is in many of these countries, the resources are limited and the needs are great. And you have to do an arbitrage between what do you fund? Do you have additional nurses versus do you have additional technicians to collect the data? The reality is we are not in an environment of unconstrained resources, and I think resource constraints tend to be the biggest limitation to the ability to do so. In many of the countries, actually, forget about even people collecting the data, but even having enough nurses to provide clinical services is a major challenge. So in my view, yeah, if you had the resources, yeah, having dedicated people doing nothing but collecting and treating data would be a huge step forward. But I'm afraid that the current resource constraints might make that scenario perhaps not completely doable in many environments currently.
So we only have 2 minutes left. So I'm going to, this is a quick one. So I'm going to pitch this to Patricia. Saskia Falk asks if you have any examples of strategies to help field workers deal with socially awkward questions, for instance, sexual practice and STD research. Nice, quick, easy.
Well, yes, they actually have quite a lot of strategies themselves, and they'll be very keen. Often if you speak to field workers in those kind of programs, they're really keen to share some of their strategies if the opportunity were to arise where they could speak openly about how they ask those questions and the wording they use to get to those answers. So I think actually, it's about looking inward within the data collection hierarchy and speaking to the people to find out their solutions. But I think people on the front line have very innovative and creative ways of reconciling some of these problems.
And maybe another quick question, probably more for you, Patricia, involves clinical trials for drugs. Are you involved in fabricating data? No, that's not what I meant to say. Are you aware of fabrication of data in clinical trials, or how clinical trials deal with this or take into account this issue?
I think, the fabrication of data has been in clinical trials has been written about, and I think it's something that is is often seen in those trials as a bad apple. So it's often an individual or one person. I think my research shows actually it's sometimes more of a systemic problem. And so, yeah, I think it's not the way that they're dealt with is they find a person who they think has fabricated the data and then they often remove that person. But sometimes these things are much more systemic than they appear. So trying to fix the system is probably what I would say is a solution there.
Okay, we're at 17:20 on the dot, and we've got through almost all the questions. Apologies for those we didn't have time for. Some closing remarks. We have 4 minutes, maybe 2 minutes for Mouhamadou, and then we'll finish with Patricia before going to our closing poll.
Yeah, thanks, Vin. I mean, it was a great conversation, and I think hopefully it gives everyone a good sense of how complex this issue is, right? It has multiple dimensions, and certainly it is an important area in the field of public health because it does impact the quality of the programming that's being done. It does impact the effectiveness of the monitoring, which relies a lot on the data that's being collected, but also the ability to learn lessons and actually determine what's working and what's not working, and therefore how to calibrate interventions going forward. I think one of the main takeaways for me is to solve a complex problem like this, we have to take a systemic approach. And what I mean by that, it cannot be just about systems or just about incentives or just about processes and methodology. I think you need to look at the entire system end to end and approach it from an integrated manner. So that is a complex issue, but I think the progress that has been made over the past few years clearly does demonstrate that we can crack this nut. It will take a lot of effort, it will take a lot of resources, but I think if we put our mind to it and we take a system-wide based approach, we can certainly make more advances even in the future.
Patricia.
Well, I'd just like to thank everybody for being involved and for giving me the opportunity to talk about my work. I've learned a lot from hearing the questions and also being on a panel with Mouhamadou has been fantastic. I think for me, really the take-home message is that data involves people. People, no matter how many numbers you see, those numbers were collected by a person from a person often, right? And every single time somebody interacts with data, they leave their fingerprint on that data somehow, either through their judgments or through their decisions. And understanding data as involving humans really allows us to take seriously the social, ethical, and all the cultural dimensions involved in data, what it means, how it's valued, what it's used for. And I think once we start to do that, I think then we can start to see that this idea about whether data is real or fake is really one about your perspective in relation to the data, but also that actually, even when we see something as being real data, that actually embedded in that all sorts of ideas about values and hierarchy and power. And similarly with fake data, you've got all sorts of ideas about, social relationships and ethics and culture. So I think what I want to do is really to emphasize the human side of data, that actually this is about human to human connection often.
Great, great summing up. So now we will turn to our poll, and I will close after that. So 4 questions, 4 options. Yes, the system is working well, mostly, but data collection should follow stricter procedures. Mostly, but M&E frameworks should be adapted. The two cannot be reconciled. So we'll wait 40 seconds for everyone to answer. So it looks like we've moved the dial here in the audience. 79% feel mostly, but we need to improve our monitoring and evaluation frameworks. So thank you for everyone for participating. We had, I think, up to over 70 participants. And I wanted to just take the final minute or so here to point out that we have, this is a series, so we have three, our next event will be on the 18th of November, Global Health Media, Raconteurs, Provocateurs, Gatekeepers, with actually some people you may have, this audience should be familiar with, Julia Bellouz, who was a journalist who's written some rather daring exposés of the global health industry and of the use of consultants. Had people very in all upset here in Geneva a few months ago, and Seye Abimbola from Australia, who has been writing about decolonizing global health. So very close to our the themes of our public series this year. Finally, I wanted to thank the whole team at the Global Health Center, especially Elisa Kodata, who's our events coordinator, Christina Petrova, Veronique Martinez, Daniela Rengli, Nora Sada in communications, and of course, Sachio, who's been coordinating the technique here. And last but not least, my co-director, Suri Moon, who puts up with me. So thank you, everyone, and have a good day.